Hello, my name is Dr. Anderson, and I'm one of the author of this abstract with the title of Pediatric Neuromyelitis Optica Spectrum Disorder, a case report of Postrema Syndrome. So in this abstract narrative video, I'm going to talk more about NMOSD, Neuromyelitis Optica Spectrum Disorder. So NMOSD, as a short form of Neuromyelitis Optica Spectrum Disorder, is an inflammatory disease of the central nervous system characterized by severe immune-mediated demyelination and the axonal damage of the spinal cord and the optic nerve. Optic neuritis and transverse myelitis are both the combination of the first common clinical attack symptoms. Area Postrema syndrome was infrequently described as an initial presentation of pediatric NMOSD. Pediatric NMOSD also accounts for 3 to 5% of all NMOSD, which usually presents in between 10 to 12 years of age. Aquaporin 4 IgG was found to be seropositive in 65% of pediatric patients in NMOSD. Symptoms of Postrema syndrome, such as intractable nausea, vomiting, and hiccups, are less commonly occur in pediatric NMOSD. In this case, we present the NMOSD case of a 10-year-old male, presents with fever, nausea, and vomiting for approximately 3 weeks before admission. He also complained of hiccups and vertigo 2 days before admission. He had previous admission and showed no improvement. On physical examination, the patient had a Glasgow Coma Scale or GCS of score 15. In the neurological examination, revealed positive nystagmus test, disturbed left upper extremity coordination, and unclear lateralization on motor examination. On the brain MRI or magnetic resonance imaging, with contrast on the fluid attenuated inversion recovery or FLAIR sequence, demonstrated a pathological intensity lesion without contrast enhancement on the right posterior medulla oblongata, or wall of the fourth ventricle, and on the periventricle of the third ventricle, extends to the bilateral optic tracts, right caudate nucleus, right internal capsule posterior, right thalamus, and right cerebral peduncle. The MRI of the thoracic spine showed no abnormalities. Aquaporin 4 serum was found to be seropositive on lumbar puncture examination. So, at the end, this patient was diagnosed with neuromyelitis optica spectrum disorder with a differential diagnosis of neuromyelitis optica and Wernicke encephalopathy. NMOSD therapy consists of 2 phases. There is acute phase management and preventive treatment. All patients with suspected NMOSD must be treated in acute phase because relapse might cause permanent sequelae. A common approach of treatment begins with intravenous methylprednisolone or IVMP with a dose of 20 mg per kilogram per day with a maximum dose of 1000 mg for 5 consecutive days, followed by the tapering off of the oral glucocorticoids after given intravenous methylprednisolone is an important thing to do too. If the initial response to the steroid is insufficient, the plasma exchange or PLEX or intravenous immunoglobulins IVIG should be considered. The recommended dose for IVIG is 2 grams per kilogram of body weight. The preventive treatment usually starts after the first attack to reduce relapse and permanent disability. Clinicians generally recommend maintenance therapy for at least 5 years. The first-line therapies in pediatric NMOSD includes IVIG, azathioprine, mycophenolate mofetil, MMF, and rituximab RTX. In this patient, he was treated with Medixon or methylprednisolone intravenous with a dose of 3 times 125 mg for 5 consecutive days, followed by IVIG with a dose of 0.4 gram per kilogram per day for 5 days. 10 days after the admission, the patient had a significant improvement in his symptoms and discharged home with an outpatient therapy of Salsep 2 times 250 mg, which is a mycophenolate mofetil. At the time of last follow-up, 2 months after diagnosis, the patient showed full recovery with no disabilities. So in conclusion, the pediatric NMOSD with a core criteria of Postrema syndrome is less common and usually appears as a relapse, not at the first clinical attack. Educating the family on possible relapse in the future and further follow-ups to evaluate the symptoms while initiating long-term immunosuppressive therapy is needed. Maintenance therapy with immunosuppressive therapy during the therapy, currently available options such as IVIG, rituximab, mycophenolate mofetil, azathioprine is recommended to prevent relapses and permanent disability in pediatric NMOSD. Rituximab is the best treatment, and it is the choice due to its benefit reducing disability, relapses, and fewer adverse effects than MMF. Thank you for listening.